Welcome to the deep dive. Today, we're taking a plunge into a really fascinating and important area, how disorders of the blood can show up right in your mouth.
Exactly. We got some detailed medical audio, a really comprehensive PDF.
Yeah, and our goal is to pull out the most crucial, maybe even surprising insights. Think of this as, your shortcut to understanding how what's going on in your bloodstream can have very real, very noticeable effects right there in the oral cavity.
It's true. We often think of the mouth as, well, separate, don't we? But it's incredibly interconnected. And what's truly interesting is how these systemic blood disorders, things happening, elsewhere in the body, can manifest with really distinct signs and symptoms right there.
And it's quite a range of conditions we're looking at, too, isn't it? From genetic stuff to complications from treatments.
Absolutely.
Which really highlights why paying attention to oral health can be, well, surprisingly valuable for your overall well-being. When you think about the mouth's environment, all the bacteria, the temperature changes, food, it's a tough place.
It is. So changes there can be quite significant.
Yeah.
It's like the oral cavity can almost act as an early warning system sometimes. So our mission, let's say, for this deep dive is to really examine these oral signs and symptoms tied to various hematologic disorders.
Yeah.
Give you the essentials without, drowning you in detail.
Okay, sounds good. So to get started, where do blood cells even come from? Let's talk about hematopoiesis.
Right. Hematopoiesis. At its core, it's just the formation of all the blood's cellular bits.
Yeah.
It all kicks off in the bone marrow with these things called hematopoietic stem cells.
Okay.
Think of them like master cells. They have this amazing ability to turn into all the different types of blood cells our body needs.
And from those master cells, they branch out, right? I remember reading about myeloid and lymphoid stem cells.
Precisely. They differentiate into two main lines, myeloid and lymphoid. Now, for today, we're mostly zeroing in on the myeloid stem cells. These are the precursors that eventually become red blood cells, carrying oxygen platelets for clotting, and those really important infection fighters, the granulocytes like neutrophils.
Gotcha.
The lymphoid line is more about specific immune responses, T cells, B cells. We'll touch on that maybe a bit with blood cancers later. But yeah, remembering myeloid gives rise to red cells, platelets, neutrophils. That's key because a lot of the oral signs relate directly to problems with these specific cells.
Right, myeloid for red cells, platelets, neutrophils. Got it. Now, to understand when things go wrong, we probably need some baseline numbers like normal ranges. The sources gave some of those.
Absolutely. Reference points are crucial. So for hemoglobin, that protein carrying oxygen in red cells, typically it's around 130 to 180 grams per liter for men and maybe 115 to 165 for women.
Okay.
Platelets for clotting, usually 150,000 to 400,000 per cubic millimeter. White blood cells, the general infection fighters, maybe 4,000 to 11,000 cubic millimeter. And then neutrophils specifically, usually between 2 and 7.5 times 10 to the ninth per liter. You don't need to memorize these exactly.
Right.
But they give context. Like knowing the normal hemoglobin helps understand why significant paleness in the mouth might point towards anemia, a drop below that level.
Okay, that sets the stage. Let's dive into specific disorders then, starting with a really common one. Anemia.
Anemia. Simply put, it's a decrease in either the volume of red blood cells that's hematocrit or the amount of hemoglobin in those cells.
Okay.
It can happen for a few main reasons. The body's not making enough red cells, they're getting destroyed too quickly, or you're losing them, like through bleeding. And interestingly, it does tend to affect women more often.
And what are the general signs we might see in the mouth with anemia?
The most common one is pallor. Just an unusual paleness of the oral mucosa, the lining of the mouth, gums, tongue, cheeks.
Why pale?
It's simply because there are fewer oxygen-carrying red blood cells circulating in those tissues. Less red pigment, basically.
Makes sense. Now, the sources got into specifics, like iron deficiency anemia. What oral signs are key there?
Well, beyond the general paleness, iron deficiency can show up with more specific things. You might see brittle nails and hair, maybe koilonychia, the spoon-shaped fingernails.
Spoon-shaped nails. Wow.
Yeah. And the tongue can become red, painful, and look oddly smooth. And also angular cheilitis, those cracks or sores at the corners of the mouth.
Angular cheilitis seems to pop up a lot in these conditions. Is there a common thread there?
Yeah, it's often a non-specific sign,
Yeah.
It can point to nutritional deficiencies like iron or B vitamins, but also infections like fungal ones. The corners of the mouth are just kind of a tricky spot, moist, prone to irritation when overall health is down.
Interesting. Okay. Now, the sources also mentioned something called Plummer-Vinson syndrome, a severe form of iron deficiency.
Indeed. Plummer-Vinson is rarer, but it's a more dramatic presentation of long-standing severe iron deficiency. The key triad is the iron deficiency anemia itself, plus glossitis inflammation of the tongue and dysphagia, which is difficulty swallowing.
And what would patients complain about?
Often a burning sensation on the tongue and just generally in the mouth. The angular cheilitis can be really pronounced too.
And what would a doctor see looking in the mouth?
A key sign is marked atrophy of the lingual papillae, those little bumps on your tongue.
Yeah.
They waste away, making the top surface of the tongue look very smooth and intensely red. The swallowing difficulty is often due to esophageal webs, thin membranes growing across the esophagus. And you might see that koilonychia, the spoon nails too. That whole constellation points towards Plummer Vinson.
Okay, so that covers iron deficiency. Let's shift gears to a genetic one. Sickle cell anemia. This is about the shape of the red blood cells, right?
Precisely. Sickle cell is inherited, caused by a mutation in the hemoglobin gene. It leads to this abnormal hemoglobin S.
Okay.
Under low oxygen conditions, the red cells distort from their usual flexible disc shape into a rigid sickle or crescent shape.
And that causes problems.
Big problems. They're less elastic, carry less oxygen, and can get stuck in small blood vessels, causing pain, organ damage.
And I remember reading it's recessive and about sickle cell trait.
Yes, autosomal recessive. You need 2 copies of the faulty gene, one from each parent, for the full disease. If you only get 1 copy, that's sickle cell trait.
And people with the trait.
They usually have maybe 40–50% abnormal hemoglobin. Mostly asymptomatic, but they are carriers.
Okay. Now, oral signs for sickle cell. The sources mention some interesting X-ray findings.
Yeah, one notable thing on dental x-rays is a reduced trabecular pattern in the mandible, the lower jawbone.
Trabecular pattern.
It's that lattice-like network inside the bone. In sickle cell, the bone marrow works overtime trying to make more red cells to compensate. This extra activity can make the bone pattern look sparser, less dense on the x-ray. Less commonly, you might see a hair-on-end appearance on skull x-rays.
Hair on end.
Yeah, imagine the skull viewed from the side. The marrow expansion between the inner and outer layers of bone can create these little bony spicules that look like hair standing up, though it's usually less pronounced than in thalassemia, another condition.
Interesting. So changes inside the jawbone. Any other oral issues reported?
Yes, there are reports suggesting a higher risk of osteomyelitis, that's bone infection in the mandible, for people with sickle cell. Also, potentially prolonged numbness or tingling paresthesia of the lower lip or chin nerve, and even asymptomatic pulpal necrosis, where the nerve inside a tooth dies off without causing pain.
Wow. And I remember the audio mentioned increased susceptibility to infections generally. Why is that?
That's critical. It's mainly due to early damage to the spleen. The spleen filters blood and helps fight certain bacteria.
Okay.
In sickle cell, those rigid cells block up and damage the spleen, often very early in life. So its immune function is compromised, making people more vulnerable to specific infections.
Got it. So sickle cell affects red cell shape. Next up was thalassemia, also genetic. Also hemoglobin. How's it different?
Thalassemia is also inherited, but the problem isn't the structure of hemoglobin, it's the rate at which it's made. Specifically, reduced production of either the alpha or beta globin chains that make up hemoglobin. This leads to fewer red blood cells overall, and the ones you have are often smaller and paler hypochromic microcytic anemia.
And there were different types, like beta thalassemia major?
Exactly.
Yeah.
Beta thalassemia major, also called Cooley's anemia or Mediterranean anemia, is the severe form. You inherit 2 faulty beta globin genes. Alpha thalassemia is more complex because there are 4 alpha genes involved. Severity depends on how many are affected.
What about the oral and facial features in thalassemia major? They sounded quite striking.
They can be, yes. Because of the severe anemia, the bone marrow goes into overdrive, expanding dramatically, especially in the skull and facial bones, leading to what's called chipmunk facies. It's a classic description in a large skull, prominent cheekbones, a depressed bridge of the nose. You also see delayed growth, teeth misalignment, malocclusion, plus enlarged liver and spleen, swollen lymph nodes. It's a systemic impact.
Chipmunk's face, she's very memorable. And the radiographic findings, similar to sickle cell.
Similar in that you can see altered trabecular patterns in the jaw. But that hair-on-end skull appearance, it's typically more pronounced, more characteristic in thalassemia major than in sickle cell. Again, due to that massive bone marrow expansion.
Okay, so both genetic, both hemoglobin, but different mechanisms and some distinct features. Let's move to aplastic anemia. This sounds really serious bone marrow failure.
Yes, aplastic anemia is rare but life-threatening. It's essentially the failure of the bone marrow to produce all types of blood cells adequately, red cells, white cells, and platelets. A failure of those precursor hematopoietic stem cells.
And what signs might point towards it?
Well, because everything's affected, the symptoms are widespread. Fatigue, lightheadedness, rapid heart rate, weakness, that's from the low red cells.
Okay.
Then the low platelets, thrombocytopenia, means easy bruising, bleeding, potentially severe, like in the eyes or brain.
And the white cells?
Low white cells, especially neutrophils, neutropenia or leukopenia, means a severely weakened immune system. High risk of infections, bacterial, fungal.
A triple threat, really. How does this show up in the mouth?
Pretty significantly. From the low platelets, you see gingival hemorrhage, bleeding gums, and petechiae, those tiny red spots on the mucosa, maybe larger bruises, purpura, or ecchymoses. The mucosa itself might look pale from the anemia. And importantly, oral ulcerations are common, often linked to secondary infections because the immune system is down.
And diagnosis relies heavily on a bone marrow biopsy.
Absolutely essential. The biopsy shows a hypocellular or even acellular marrow, very few blood-forming cells, mostly replaced by fat. Blood tests confirm pancytopenia low counts across all cell lines. Specific criteria often involve very low granulocyte, platelet, and reticulocyte counts.
Alarmingly low counts indeed. Okay, moving to a more specific white cell issue, neutropenia, low neutrophil count, right?
Correct. Neutropenia is specifically a low count of neutrophils, key bacterial fighters, below 1,500 per cubic millimeter in adults. This significantly impairs the body's ability to handle bacterial and some fungal infections.
And the source material hinted oral infections could be an early sign.
Yes, clinicians need to be aware of that. Oral lesions can be the first clue. Typically ulcerations, often on the gums, the gingival mucosa, likely because of the high bacterial load there and just frequent minor trauma. But a key feature of these neutropenic ulcers is that they often lack the usual red inflamed border, the erythematous periphery.
No red border.
Right. It suggests a blunted immune response. In more severe or chronic cases, you might even see premature periodontal bone loss, even baby teeth falling out early.
So mouth ulcers without that typical redness, a big red flag for potential neutropenia. And what if the count drops really low?
Below 500 neutrophils per cubic millimeter, the risk of serious systemic infections like pneumonia skyrockets. And then there's a granulocytosis, basically, a near complete absence of neutrophils.
That sounds critical.
It's a medical emergency. High risk of severe, fast-moving infections. Patients might feel generally unwell, severe sore throat, swelling, fever, chills, bone pain, potentially sepsis.
And orally in a granulocytosis.
Oral lesions are almost always present and severe, often necrotizing tissue death, leading to deep, punched-out ulcers on the cheeks, tongue, palate. The gums are particularly vulnerable, sometimes resembling NUG necrotizing ulcerative gingivitis with tissue destruction, pain, bad odor.
Okay, so severity matters. Now, the sources also mentioned cyclic neutropenia. That sounds weird.
It is quite unusual. Cyclic neutropenia is rare, often idiopathic cause unknown, though sometimes linked to a gene mutation, ELA2.
What's cyclic about it?
It's characterized by regular, predictable dips in the neutrophil count, usually on about a 21-day cycle. So every 3 weeks or so, for a few days, the count plummets, making the person susceptible to infection. Then it recovers spontaneously.
Fascinating rhythm. What are the oral issues during those low periods?
During the dips, patients often get recurrent fevers, fatigue, swollen glands, sore throat, and importantly, recurrent oral ulcers, especially on the gums. And like in chronic neutropenia, you can see premature periodontal bone loss and early loss of primary teeth, often starting at a young age.
So the recurring pattern, especially the oral ulcers timed with the cycle, is key there. Okay, let's switch to platelets. Thrombocytopenia, low platelets, high bleeding risk.
Exactly. Thrombocytopenia means a low number of circulating platelets, those crucial bits for stopping bleeding. Hemostasis. Normal is 150,000 to 400,000 per cubic millimeter. Thrombocytopenia is diagnosed below 150,000.
And why might platelets be low?
Several reasons. Could be decreased production in the bone marrow, increased destruction in the body, or they might get trapped in organs like the spleen that's sequestration.
What are the clinical signs? When do you notice it?
Often not obvious until the count drops below about 100,000. Then you start seeing petechiae, those tiny pinpoint hemorrhages, often in clusters on skin or mucous membranes, including the mouth.
Okay.
Larger areas are ecchymoses or bruises. A big collection of blood is a hematoma. In the mouth, spontaneous gum bleeding is common, or excessive bleeding after minor things like brushing.
So easy bruising, gums bleeding, easily definite red flags. How is it managed?
Depends on the cause and how low the count is. If it's a drug reaction, stopping the drug often helps.
Right.
If the risk of serious bleeding is high or the count is dangerously low, then maybe platelet transfusions, corticosteroids, or other meds to boost production or reduce destruction.
Okay. We've covered low counts. What about the opposite? Polycythemia vera, too many red blood cells.
That's right. Polycythemia vera is a rare type of blood cancer, a myeloproliferative neoplasm. It's marked by an abnormal increase in red blood cells.
Just red cells.
Often platelets and granulocytes are elevated too. Usually hits older adults, median age around 60. And interestingly, a specific gene mutation, JAK2, is found in most cases.
So, too many cells. What problems does that cause?
The extra red cells make the blood thicker, more viscous. That, plus often high platelets, really increases the risk of blood clots, thrombus formation.
Bleeding too.
Serious events, TIAs or mini strokes, full strokes, heart attacks, high blood pressure, and an enlarged spleen, splenomegaly, are also common.
How do you treat having too much blood?
Often starts with phlebotomy, literally removing blood, maybe 500 milliliters regularly, to lower the red cell mass and viscosity.
Okay.
Low-dose aspirin is usually given to reduce clot risk. Longer term, meds like hydroxyurea or interferon alpha might be used to control cell production. If platelets are super high, other drugs might target those specifically.
Interesting. Okay, from too many red cells, let's go to a vitamin deficiency affecting them. Pernicious anemia, that's about B12, right?
It is a vitamin B12 deficiency, yes. But typically the root cause isn't poor diet. It's the body's inability to absorb B12 from food.
Why can't it absorb it?
Due to a lack of intrinsic factor. It's a protein made by parietal cells in the stomach lining, essential for B12 absorption in the intestine.
And why is intrinsic factor missing?
Often it's an autoimmune issue. The immune system mistakenly attacks and destroys those parietal cells. So no intrinsic factor, no B12 absorption, even if you eat enough.
Got it. What are the oral signs and symptoms here?
Often, complaints focus on the tongue. A painful burning sensation is common. The tongue can look unusually red and smooth because the papillae atrophy waste away.
Smooth and red tongue.
Yes, sometimes called Hunter's glossitis or Moeller's glossitis. You might also see angular cheilitis again, oral thrush, candidiasis, recurrent ulcers, or just a general redness and inflammation of the mouth lining, diffuse erythematous mucositis.
That burning, red, smooth tongue sounds quite distinctive. And treatment is usually effective.
Yes, fortunately. Since absorption is the issue, B12 is typically given by injection, bypassing the gut entirely. That usually works very well.
Okay, we've hit a lot of anemias and platelet issues. Let's turn to blood cancers. The leukemias.
Leukemias are malignancies. Cancers originating from those hematopoietic stem cells in the bone marrow.
What goes wrong?
You get uncontrolled growth and buildup of abnormal, non-functional white blood cells. They crowd out normal cells in the marrow and spill into the blood.
And they're classified in different ways.
Broadly, yes. By how fast they progress, acute or chronic. And by the type of white cell involved, myeloid or lymphocytic lymphoblastic.
Are there known risk factors for leukemia?
Some things are associated with higher risk, yeah. Certain genetic syndromes like Down syndrome, Klinefelter syndrome, environmental factors like pesticides, benzene, ionizing radiation. Even prior chemo or radiation for other cancers can sometimes lead to secondary leukemia later.
What general symptoms might suggest leukemia? They sounded quite nonspecific.
They can be persistent fatigue, shortness of breath, enlarged spleen or liver, swollen lymph nodes, easy bruising or bleeding, getting infections more often or more severely. It can be tricky for early diagnosis sometimes because these symptoms overlap with many other things.
And the white blood cell counts can be sky high, I remember.
Yes, dramatically elevated. Instead of the normal 4,000 to 11,000 per cubic millimeter, you might see counts of 100,000, 400,000, or even higher. But crucially, these are abnormal, non-functional cells. They don't fight infection properly, though sometimes, rarely, the count might be normal or even low, which adds to the complexity.
Okay. The sources mentioned 4 main types, ALL, AML, CLL, CML. Can you briefly differentiate them?
Sure. All acute lymphocytic leukemia, most common in kids, but happens in adults too. Aggressive. AML, acute myeloid leukemia, most common acute leukemia in adults, also aggressive.
Okay, those are the acute ones.
Then CLL, chronic lymphocytic leukemia, most common chronic type, mainly older adults, often slow-growing. CML, chronic myeloid leukemia, usually adults, has a specific genetic marker, Philadelphia chromosome, often develops slowly. So yeah, differences in cell type, lymphoid versus myeloid, and speed, acute versus chronic.
Acute needing faster treatment, chronic slower. L for lymphocytic, M for myeloid. Got it. How do leukemias show up in the mouth?
Oral signs are quite common, sometimes even the first signs. You might see petechial hemorrhages, those tiny red spots again. Gingival hemorrhage, bleeding gums, maybe spontaneous.
And gingival enlargement.
Yes, a characteristic gingival enlargement. It's often described as diffuse, boggy, non-tender swelling. This is particularly seen in acute monocytic leukemia due to leukemic cells actually infiltrating the gum tissue.
Wow, the cancer cells themselves are in the gums.
Yes. Patients can also get oral ulcerations, often deep, punched out with a grayish-white base on gums, tongue, palate. And oral candidiasis, thrush, is common because the immune system is compromised.
That gingival enlargement due to infiltration sounds very specific and concerning, and treatment is intensive.
Generally, yes. Highly dependent on the exact type, stage, patient's health. But common approaches include chemotherapy, often combination drugs, radiation, targeted therapies attacking specific cancer cell features, immunotherapy, and sometimes stem cell or bone marrow transplant.
Wow, okay. We have certainly covered a huge range of blood disorders and their, well, sometimes really surprising links to what happens in the mouth.
It really does underscore how interconnected everything is, doesn't it?
Yeah.
The mouth isn't isolated. It truly serves as a valuable window into our overall systemic health.
Absolutely. Some of those connections were so striking, the chipmunk facies in thalassemia, ulcers without red borders in neutropenia, that hair on end x-ray.
Yeah, memorable signs. And recognizing them, even subtle ones, can be just crucial for catching serious underlying conditions earlier and getting people the right management.
So as we wrap this up, it really makes you think, doesn't it? How seemingly separate body parts can hold clues to bigger health puzzles. Maybe for our listeners, it's a prompt to pay even closer attention to subtle oral changes. It's a powerful reminder about careful observation and just how integrated our well-being is. Definitely encourages further exploration if any of these conditions caught your interest.
Indeed. There's always more to learn, and understanding these links can really empower you to be more informed about your own health and, the health of people around you.